Good afternoon or good morning, depending on where you are. Happy Breastfeeding Month. I hope you are participating and taking advantage of all the breastfeeding resources being shared this month. We know it's a really busy time, and we really appreciate you taking your time and joining us today. We also want to acknowledge the CDC Reach and SPAN recipients participating in this webinar today. We hope you will find the information shared here today helpful. It is our hope to bring Laurel back next year for a joint office hours session for the recipients. You see the poll going on, so we just wanted to know where you're coming from in the breastfeeding continuum of care. So please vote. We're gonna have this up for about extra minute or so. So my name is Harumi Riley. I'll be your moderator today, and on behalf of NACCHO's breastfeeding team, I would like to welcome everyone here to today's webinar, Unpacking Barriers and Facilitators to Exclusively Breastfeed a Hospital Discharge. I am so excited to be here with Laurel Bookhart today, our speaker. She's a doctoral student at Emory University, and CDC and NACCHO have been supporting their research for the past year to understand more in details the factors that facilitate exclusive breastfeeding rates at discharge. As you know, exclusively breastfeeding the first few days after birth is critical for establishing and sustaining breastfeeding in the long run. And we definitely know that as a nation, we need to increase the exclusively breastfeeding milestone for 6 months. However, in the United States, about 17% of infants are supplemented with formula within 2 days of life for different reasons, including many reasons that are not medically necessary. So today's webinar will highlight findings from 2 studies that Laurel is conducting. One is being conducted at a baby-friendly hospital in Georgia, was conducted, and another one is an analysis of the latest Unpacking results on reasons for early formula supplementation. In this webinar, we also discuss potential solutions that to improve healthcare system, breastfeeding support, and continuity of care to improve exclusive breastfeeding rates. We are happy to announce that we approved to provide one LSERP. We will share more information about it at the conclusion of this webinar. And please do use the Q&A box to submit questions throughout the webinar. We will address them all in the end of the webinar. If you have any technical difficulties, please use the chat box to contact our team. This webinar is being recorded and will be shared with all who registered within the next week or so. I also wanted to say that the SERPs are valid for a year. So if you don't get to do your post-test today, you'll be able to do it within a year. So here are our acknowledges and disclosures. We will not be just this research is supported by the NACCHO's Reducing Disparities in Breastfeeding Through Continuity of Care project, which is funded by CDC, the Division of Nutrition, Physical Activity, and Obesity, the NPAO. We don't have any conflict of interest to declare, and I just wanted to make a note here that these slides will not be shared yet, because both studies, the Grady and the Unpacking, have yet to be published. They are under peer review, and when it's published, we will share a brief report tailored to lactation support providers working in communities. So be on the lookout for that. And before we get to Laurel, I would like to share some resources and introduce NACCHO for those who are not familiar with us yet. And again, August is Breastfeeding Month, so happy Breastfeeding Month. I hope you have seen these resources circulating there. You know, every August, CDC releases the new breastfeeding date results from the National Immunization Survey. These include updated national, state, and social demographic breastfeeding rates for infants born in 2017. It also shows results of breastfed children who were supplemented with formula within 2 days of life. Some of the preliminary analysis of this new data suggests some backsliding in reducing early formula supplementation of breastfed infants. So today's topic is very timely and important to understand more of the individual and hospital level context, even within baby-friendly designated hospitals. So the next one shared last month was the new Unpacking survey results. Unpacking, as you may be familiar with, is a biannual census of hospitals providing maternity care in the United States and territories. It started in 2007 to monitor infant feeding practices and policies during birth hospitalization. This year, results show newly designed survey results that was actually launched in 2018. So given these changes, it's important to note that the results of this 2018 Unpacking survey cannot be compared to results from previous years. So nationwide, 70% of the eligible facilities chose to participate in the 2018 Unpacking. You can go to the CDC link to see the data and also get your state report. So they have reports for each state and see how they're doing. I'll share these links. I know you can't click on the link, so I'll share these links shortly in the chat box. And in today's webinar, Laurel will share some findings from her analysis of the most common reasons why breastfed infants are supplemented with infant formula in hospital. And this was the first time that CDC had this question about early formula supplementation in the Unpacking survey. And lastly, I hope you're taking advantage and participating of the NBCC Reimagine. This is the free USPC online conference. Every week they're releasing new sessions. I added the link there to access and receive free continuing educations. I also highlighted a session that I watched yesterday. It's the week 2, and I enjoyed, and I think it goes well with the themes of today's webinar. So it's the Centering Patient Voices and Organizational Readiness for Change, Lessons Learned from New York City Hospital Baby Friendly. And I wanted to introduce us for those who doesn't know us. NACCHO is the National Association of County and City Health Officials, comprised of nearly 3,000 local health departments across the United States. Our mission is to improve the health of communities by strengthening and advocating for local health departments. So NACCHO advances the work of health departments and community partners to create healthy and thriving communities. Within NACCHO, we are the breastfeeding program under the maternal, child, and adolescent health team. We have tons of breastfeeding resources developed through this past 6 years. We have assisted over 100 communities to implement breastfeeding projects and continuity of care. You can see there the link to our website. We have journal articles, a bunch of capacity briefs, program implementation guides, and tons of webinars. Many of these webinars, we have some of our hospital grantees presenting, so that might be of interest to you. And many of these webinars still carry free continuing education. And here is the NACCHO's newest breastfeeding resources. We just released about 2 weeks ago this community health centers and breastfeeding report. We have worked for the past 2 years with FQHCs, so they could build internal continuity of care, similar to the baby-friendly initiative for hospitals structure with policies and training and all that. And there's great content here and also a lot of tools and templates available in the appendix section. So you can, I'll be sharing these links in the chat box too. And talking about the USPC conference, last week we presented with ASTO in one of their sessions, highlighting the reach and span recipients from CDC. And then Erica is going to be sharing how to join our newsletter. If you haven't done so, that's where we share a bunch of our resources and partner resources as well. Okay, so finally, we're here for the main content of this webinar. Here are our learning objectives for today. So describe the importance of early exclusively breastfeeding to create baseline for long-term breastfeeding success. Identify factors influencing exclusively breastfeeding at Grady Memorial Hospital. Discharge. Describe the reasons for formula supplementation of healthy newborns in the US during hospital stay and the relationship with demographic factors. And list short-term and long-term solutions to improve healthcare system breastfeeding support and continuity of care. So as you can see, although we recognize that the impact of COVID on breastfeeding are on everyone's mind, just to say that we will not be addressing that topic of COVID on this call. Laurel's research being presented here was conducted prior to the pandemic between December 2018 through May 19. If you are interested in resources about COVID and breastfeeding, please join our monthly newsletter. We're sharing all the newly released COVID resources, and also USBC. You can reach out to them. They have convened the Infant and Young Feeding COVID Constellation, and they have been doing intensive work on this field, including advocating for the newest CDC and AAP guidance recommendation to room in instead of infant separation. So this group includes lots of experts more prepared to answer any COVID and breastfeeding related questions. So here is our beautiful presenter for today. Laurel is a doctoral student in the Nutrition and Health Sciences program at Emory University. She's currently completing dissertation work on determinants of early infant feeding practices in the US hospitals. This includes work with Grady Memorial Hospital, located in Atlanta, Georgia, to improve exclusively breastfeeding at hospital discharge, which she will be presenting today. In addition to her current work, she has worked as a registered dietitian and international board certified lactation consultant in the capacity of director of WIC in Halifax County, North Carolina. So Laurel, if you're ready, you can start sharing your slides.
Sorry for the technical difficulties, and thank you, Harumi, for the introduction, and hello to everyone. I am very happy to join you during World Breastfeeding Month, and I'm excited to present work on unpacking barriers and facilitators for supporting women to exclusively breastfeed at hospital discharge. And as mentioned today, today's presentation will include two bodies of work. So first, we will look at a local case study at Grady Memorial Hospital. And then second, we'll look at a national level study using the Maternity Practices in Infant Nutrition and Care Survey, which is also known as the NPINK survey, as Harumi mentioned. So for both of these studies, we look to understand factors influencing exclusive breastfeeding, as well as the flip side of that in terms of formula supplementation. And so the time frame that we were specifically interested in was early exclusive breastfeeding, since that time is critical to establishing a milk supply needed for longer durations of breastfeeding. And then additionally, we had specific interest in addressing demographic disparities that exist and the healthcare system breastfeeding support. So what could be done to further improve the support that is there? And as Harumi mentioned, the results are preliminary and have yet to be published, but please stay tuned for publications in the future. And so here is listed the outline that we will follow for today. So we will first discuss a background and then move into the case study at Grady, and then move into the national level study. And then we'll tie together both pieces of work in the conclusion. We'll also save time at the end to answer any questions that you may have. Next slide, please. And next slide. So the physiology of lactation and establishing a milk supply are important to understand when considering this topic of early exclusive breastfeeding. So I will walk through some of the key components of the physiology. Lactogenesis 1 begins during pregnancy, approximately around 16 weeks. And the distinguishing characteristic for this phase of lactogenesis is that colostrum is available to the infant at delivery. And this first phase of lactogenesis is under endocrine control or hormonal control, in which the mother's hormones tell the breast to produce milk. What's key for this context when considering hospital practices as it relates to the physiology of breastfeeding is lactogenesis 2, which we have here on the screen. This second phase occurs between 30 and 72 hours following the delivery of the placenta, when mothers and infants are typically in the hospital following birth. And so for this phase, the distinguishing characteristic is the onset of copious milk secretion. The control phase of the control of this phase of lactogenesis is under this transition in which milk production is switching from endocrine control to autocrine control. Next slide, please. And so with autocrine control, the primary stimulus for milk production is direct stimulation, as we see with this positive feedback loop in the picture to the right. This is where we see this transition where the control switches from the mother's hormones only to direct stimulation from infant suckling. Next slide, please. And so this second phase of lactogenesis is important for establishing a milk supply that's needed for this third phase, which is the maintenance phase of breastfeeding. Next slide, please. What we also know about the physiology of lactation is that formula supplementation during the second phase of lactogenesis challenges this biological pathway to establishing a milk supply needed for continued breastfeeding. And so studies have found that formula supplementation during this time period has been associated with decreased breastfeeding duration. And so just to summarize in terms of the lactation, with this lactogenesis 2, it typically begins while the mother is in the hospital following delivery, and it's a very sensitive time for establishing the milk supply needed for longer durations of breastfeeding. And so here on this slide, when we're considering the physiology and the dose-response relationship between breastfeeding and the associated health benefits, exclusive breastfeeding for the first 6 months of life is recommended by both the World Health Organization and the American Academy of Pediatrics. And so here presented our breastfeeding data. And so we see from data from the National Immunization Survey for infants born in 2017, which, as Harumi just mentioned, was released at the beginning of this month. We see that only 25.6% of all infants born in the US are exclusively breastfed at 6 months, as indicated by this green line. We see disparities in certain subpopulations. So presented here also are data on breastfeeding at 6 months, stratified by race and ethnicity. And we see, in taking a closer look at these data, that disparities exist for Hispanic infants and non-Hispanic Black infants. Next slide. Thanks. We also see disparities by education, in which infants whose mothers have less than a college education breastfeed exclusively for 6 months at proportions less than the national average, as well as infants whose families have incomes that are less than 200% of the poverty income ratio. Next slide, please. Hospital level disparities also exist. Grady Memorial Hospital is located in urban Atlanta, Georgia, and serves a high proportion of low-income individuals. It also serves a very diverse patient population. So this includes a variety of races and ethnicities, as well as a large immigrant population with multiple languages spoken and a diversity of culture within those characteristics. And so based on data from the Joint Commission, which is a major hospital accreditation body, we see that Grady has an exclusive breastfeeding rate at hospital discharge of 33%. And that's below the state average in Georgia of 40%, as well as below the national average at 52%. Next slide, please. Grady has made great strides in improving their exclusive breastfeeding at discharge. Excuse me. In 2015, it was 11%. And during the year of 2015, the hospital achieved baby-friendly designation. And since then, the hospital has improved to 33% in 2019. However, as mentioned, this is still below the national as well as the state prevalence. So taking a deeper dive there at the context at Grady, we see a complex organizational structure. Grady provides staffing for the lactation consultants as well as the nurses. There's also a WIC office located on campus within the hospital, which staffs lactation consultants, but additionally staffs nutritionists that provide WIC services during the prenatal period, as well as the early postpartum period. And during the time that this study was conducted, enrolled participants after delivery while still inpatient. In terms of physicians who provide care there at Grady, both Morehouse School of Medicine and Emory School of Medicine attending and resident physicians provide care to mothers. So it is indeed a teaching hospital. And the key takeaway from this slide is that there's this complex organizational structure there at Grady that makes providing comprehensive lactation care a bit more challenging. Next slide, please. This work at Grady started with Grady recognizing the need to improve the proportion of women exclusively breastfeeding at hospital discharge. From there, Grady proactively reached out to Emory School of Public Health to address the need, and we established a core team which included not only Emory researchers, but also Grady administrators and Grady staff, and they were instrumental to guiding this research along the way. Next slide, please. We first went to the literature to see what exists in terms of factors and support for early infant feeding practices. We found that work has been done, and a useful model includes the social ecological model. And so this model is especially helpful when considering marginalized populations with breastfeeding disparities, because it shifts the onus from individual decision-making to include the context in which moms have to make decisions about breastfeeding. And so these studies have found that factors influencing early infant feeding practices exist across the social ecological model. So for example, we see that self-efficacy related to milk supply is a factor at the individual level. We see that at the interpersonal level, there's the influence of family and provider support. At the community level, we see WIC services, and then at the organizational and hospital level, we see access to breastfeeding support services. Next slide, please. Although those studies exist as it relates to infant feeding practices, there's often a large focus on breastfeeding initiation as well as breastfeeding duration, with limited focus on exclusivity. Also, within that piece, there's limited focus on healthcare system breastfeeding support for early exclusive breastfeeding. And this may be a potential missing link connecting breastfeeding initiation to breastfeeding duration. And so with the work at Grady and this national level study, we are hoping to address this literature gap. Next slide. And so this also looks at the national level study where we are not only thinking about demographic disparities, but also looking at how that connects to breastfeeding practices and then the underlying reasons for formula supplementation. So this national level study allowed us to look at the underlying reasons for formula supplementation and what may be going on there. Next slide, please. So now we're going to move into a local case study, specifically at Grady Memorial Hospital. Next slide, please. Next slide, please. Okay. Oh, sorry, can you go back to the previous slide? So we conducted there at Grady a qualitative study, which included interviews with 38 participants across the social ecological model. Of note, all interviews were conducted between December 2018 and May of 2019. And so, as Harumi mentioned, this was before the COVID-19 pandemic. And so we didn't specifically address items related to that with this study. But what was included in the study were 20 mothers who gave birth to healthy singleton infants without medical contraindications for breastfeeding, as defined by the Academy of Breastfeeding Medicine protocols. So these were healthy mothers. We did not include mothers and infants or mothers whose babies were admitted to the NICCU, only healthy infants. And then within that individual level, we included 10 mothers who were exclusively breastfeeding and 10 mothers who were not exclusively breastfeeding, so that we could compare the two groups and truly get at the research question of facilitators and barriers to exclusive breastfeeding. At that interpersonal level, we included participants who provide direct patient care and support to breastfeeding mothers. This included extenders, or those who extend the care of the physicians, such as nurses and lactation consultants. Also of note here, our sampling strategy provided heterogeneity so that we could get a sense of range of responses. So, for example, we not only included a day shift nurse, but also a night shift nurse. And then at the community level, we interviewed participants from the WIC organization there on site at Grady, as well as the Leche League, which had a volunteer that provided care or provided support to mothers after delivery in the hospital. At the organizational level, we included those who influenced the care provided by others. And so, for example, that level included the chief of service for both pediatrics as well as OBGYN. And so many of those at the organizational level and hospital level also provided direct patient care. Next slide, please. Here I briefly listed some key demographic information on the 20 mothers who participated in the study. So to the left of the slide, we see that race and ethnicity are listed, with 65% being Black or African American, with a variety of other races and ethnicities. To the upper right of the slide, we see that over half of the participants had attended some college. And then to the bottom right, we see that 70% of the participants were WIC participants. Next slide, please. So from the interviews conducted with mothers, clinicians, community organizations, and hospital administrators, the findings clustered around these three overarching concepts. So first, we have here family and culture, and then next we found knowledge and experience, and then a large component included lactation management support. And so in the following slides, I'll present examples from each of those overarching concepts. Next slide, please. So starting with family and culture, we found that family support was important even during the hospital stay for exclusive breastfeeding. Family support was a facilitator when present, as indicated by the positive sign by breastfeeding benefits. We found that family members who were aware of the benefits would encourage breastfeeding during vulnerable or challenging times when mothers consider supplementing with formula. And so this would go on to support exclusive breastfeeding. Here we have a quote from an exclusive breastfeeding mother of two who describes the support of the father of the baby while in the hospital. She says, "He's like my backbone." I'm thinking like, well, why don't we just formula feed? And he's like, why are you thinking about formula feeding when you've got breast milk that you can produce? So in contrast to that support, we also see lack of family support was a barrier as indicated by the negative sign by caretakers. Here we found that family members who visit while in the hospital that are not familiar with breastfeeding, but who will serve as caretakers later when the mother is returning to work or school, may discourage exclusive breastfeeding while she's there in the hospital because of the fear that she will not have enough expressed or pumped breast milk when the mother is separated from the baby later. Next slide, please. The second concept included knowledge and experience, and prenatal education was a major theme for knowledge and experience. We found that a personable approach was a facilitator and was found to be most effective in motivating women to move beyond initiating breastfeeding to breastfeed exclusively. So here in the green, we have one of the most powerful quotes from this study. This is an exclusive breastfeeding mother of 4. She had a previous bad experience breastfeeding her 3rd child and did not want to try it again. However, she goes on to say, when I was waiting for my ultrasound, she sat down and really talked to me about it. And it's the way she came at me that made me feel comfortable to go ahead and try it. I wasn't going to read no pamphlet about my breastfeeding because that's just words on a piece of paper. And so from this quote, we see an example of not only motivating mother to give breastfeeding another try, but also motivating her to do so exclusively by taking this personable approach. We found that providing education after admission to the hospital was not an effective time of breastfeeding education delivery. Most mothers are often overwhelmed during this time, and this makes it harder to absorb and comprehend the information. Next slide, please. The third concept included lactation management support. And so the first item that I will present today related to this includes WIC services, which serve as both a facilitator and a barrier. Many reported that the additional benefits offered to mothers who are exclusively breastfeeding served as a facilitator, including the prenatal education as well as the practical help in larger food packages. However, we also see that the staff reported that the distribution of WIC vouchers after delivery while the dyad is in the hospital undermines the promotion of exclusive breastfeeding. And so here we have a quote from an extender who says, WIC is like running our whole floor. They'll say, you know, I'm going to do both, so I need to get my vouchers for formula. So you're like, what happened to our exclusive breastfeeding? And then they're like, I have to go back to work, and you start hearing that conversation. Next slide, please. Also for the third major concept of lactation management support, adequate practical help was found to be a theme. This was often reported to be the most influential facilitator for continued exclusive breastfeeding while in the hospital. So this included help with latching as well as addressing any concerns related to breastfeeding that the mother may have. However, we did see that untimely or wrong information was a barrier in which there were 2 key cases where mothers planned to exclusively breastfeed during the prenatal period, but supplemented due to inadequate practical help. So one of which was a first-time mother that was told that she had to stop breastfeeding because she underwent a CT scan and was later told that that wasn't true and could have continued breastfeeding. The second case included a mother who took many steps to prepare to breastfeed, including attending a breastfeeding class and doing her own research to prepare. However, we have a quote here from her who said, she went on to say, I put her on formula about yesterday afternoon. I couldn't take it anymore. It was hurting so bad. Yeah, then my extender came in and showed me the correct way. And ever since then, I've been able to breastfeed. So maybe if this mom had gotten help a little bit earlier in her hospital stay, she would have gone on to breastfeed exclusively. Next slide, please. So After completing this study, we presented the findings to the breastfeeding quality improvement team. This team met weekly to discuss quality improvement efforts and measures related to breastfeeding, and included representatives from obstetrics, pediatrics, lactation, and WIC. So once those findings were presented, this team then selected the areas of focus for the short-term solutions. And those short-term solutions are those that could have been implemented without additional funding or additional personnel. And separate working groups were then formed for each topic to make sure that we had representatives that could really speak to the issue and help us dig a little bit further. Next slide, please. So this first area of focus included practical help in providing, making sure that timely practical help was provided. In those separate working groups, we looked more in depth at the topic and developed a short-term solution. And when we took a deeper dive to understand that issue, we found that the role of nurses and physicians was previously defined to include providing basic breastfeeding support. So for example, helping to facilitate skin to skin and helping with the initial latch. And then the role of the lactation consultant included providing advanced breastfeeding support to mothers who may be having problems. And it was consult driven because of limited staffing. However, we did see a misalignment of these roles and them becoming crossed. So nurses and physicians were placing consults for basic support, such as helping with the initial latch and the skin to skin. Mothers who start out exclusively breastfeeding or who may encounter a more advanced problem were not receiving the support needed because the lactation consultants were being driven more towards the basic support instead of the more advanced help. And so the short-term solution included working with nurse leadership to reiterate the roles of nurses to provide the basic breastfeeding support. This also allowed lactation consultants providing that practical support to prioritize exclusive breastfeeding mothers on the first day of life, so that mothers who were exclusively breastfeeding could get the support that they needed. Next slide, please. And so the next area of focus included WIC services. And when taking a deeper look, we found that WIC was a facilitator, which includes provision of prenatal breastfeeding education, and also the practical help in larger food packages. However, on the flip side of that, we saw that there were barriers there, including the underutilization of WIC prenatal education. And then next there, very key to exclusive breastfeeding at hospital discharge, we found that mothers requested formula from nurses to assure access to WIC formula later, as we saw with the quote from the extender earlier. And in conducting this study, there were some cases we discovered in which mothers were requesting the formula, but not using it. And so they were being documented in the hospital records, medical record, that they were supplementing with formula, but indeed they had not given the formula to the baby yet. And so in that case, they would have technically been exclusively breastfeeding, but they were being documented as breastfeeding but supplementing. And so the short-term solutions included maximizing prenatal WIC enrollment and asking prenatal clinicians to promote WIC enrollment during pregnancy. Next, we also discussed conducting postpartum WIC enrollment on the second day of life. And so this would give the mother a chance to potentially resolve any issues and become more comfortable with breastfeeding without the immediate pressure of having to choose a food package right after she's delivered. So when nutritionists come in to visit the mother while in the hospital and ask how you're planning to feed the baby, the mother doesn't feel that pressure to report that she's going to exclusively breastfeed. And hopefully from the previous step to also get the help and support that she needs before she makes that decision. And then finally here, the questions about services offered were determined to be best answered by WIC personnel due to frequent state level policy changes and specific WIC guidelines. Next slide, please. Okay, so long-term solutions included hiring more lactation support staff. And as I mentioned earlier, these long-term solutions are solutions that would need additional funding as well as additional staff to implement. So with this, we found that it's important to have more staff to be able to provide the support needed. And I'm very pleased to report that we were able to use the findings from this qualitative study to support a business case to leadership to prioritize funding to hire an additional IBCLC who's been hired and is currently working there. Next, in terms of long-term solutions, we have comprehensive prenatal education. And so not just focusing on the benefits of breastfeeding, but also providing practical education. And what was also unique about this study is the insight that we developed about WIC and making sure that this education on food packages is being provided during the prenatal period so that mothers can make an informed decision that isn't rushed. And also that individualized counseling to address any concerns that moms may have. And then finally, in terms of long-term solutions, making sure that what's developed is multi-pronged, and it includes multiple levels of the social ecological model. So family, as well as clinicians and community organizations, and also administrators. Next slide, please. So now we will move into the national level study. Next slide, please. And so for this study, to get an understanding of the reasons for formula supplementation, we used data from the 2018 Maternity Practices in Infant Nutrition and Care Survey, which is also known as the NPINC survey. And this survey collects information on routine maternity care and infant feeding policies and practices. It's also administered by the Centers for Disease Control and Prevention every 2 years. And it's a voluntary census of all maternity hospitals in the US and US territories. And you can go back to the previous slide. Thank you. In 2018, hospitals were asked, what are the 3 most common situations that lead to recommendations or requests for formula for healthy breastfed newborns during the hospital stay? And so this was a free text entry for the survey, and it started with an in-depth analysis of this. So this allows us to zoom out and take a look at what's going on nationally. Next slide, please. So these are the preliminary results. A total of 2,045 hospitals responded to the free text question, and this represents about 70% of US maternity hospitals. And so hospitals reported 7 overarching reasons for formula supplementation as presented here. So the first of which included medical indications, which were most frequently reported. And we see that a total of 72% of hospitals reported this. This is followed by maternal preference, requests, and feelings about breastfeeding at approximately 56%. And then next we see that 50% of hospitals reported lactation management related issues, and 36% reported physical but non-medically indicated reasons for formula supplementation. And less frequently reported were social influences, cultural, societal, or demographic related factors, and then medical staff and institutional practices. And so in the following slides, I'll walk through each of these overarching reasons. So as mentioned, the most frequently reported reason for formula supplementation by hospitals were medical indications. These are those listed in the Academy of Breastfeeding Medicine Clinical Protocol number 3 on supplementary feeding and the healthy term breastfed neonate, and includes, for example, hypoglycemia, weight loss, and jaundice. What's key to note about this category is that we're not able to determine from this question and answers provided whether or not lactation management support is provided before supplementation is given for these conditions. And then somewhat related, hospitals reported physical but non-medically indicated reasons for formula supplementation. These are reasons related to the physical state of the dyad. However, in contrast to what we have here on the left of the slide, these are conditions not listed in the ABM protocol. So for example, maternal exhaustion or fatigue, birth weight or size, and generalized pain or discomfort of the mother. Next slide, please. Maternal preference requests and feelings about breastfeeding were specific to the mother. And so this included mentioning of feelings such as lack of confidence or frustration. And then to the right of the slide, we have lactation management related issues. These are those issues directly related to lactation in the act of breastfeeding. So for example, perceived low milk supply, concern about infant hunger, as well as latching issues. Next slide, please. And so about 20% of hospitals reported social influences, which includes the influence of the mother's closest relationships. So for example, both parents making requests and not just the mother alone, and then the influence of family and friends, as well as lack of support from family and friends. So to the right, we have medical staff and institutional practices. This includes doctors or nurses, medical staff's limited knowledge, and the hospital policies or practices. And for example, here we have doctors' requests that were not specifically related to medical indications, as well as the staff not having enough staff to provide the services that mothers need. Lastly, we have here reports of cultural, societal, and demographic related factors. This includes perceived cultural norms, societal factors, or demographics of the population served. Next slide, please. So the key takeaway from this national level study of the most common reasons for formula supplementation includes that medical indications are most frequently reported. However, it's unclear if appropriate lactation management support is provided before formula supplementation is given. And also to the bottom left there, we know that based on current literature that certain factors such as physical but non-medically indicated condition, as well as lactation management related issues, are potentially modifiable if adequate healthcare system breastfeeding support is provided. And to the right of the slide, potential solutions based on the findings include making sure that breastfeeding education is culturally tailored and delivered to mothers and families during the prenatal period. And also, additional lactation management support may be needed to prevent formula supplementation during the hospital stay. Next slide, please. So in conclusion, bringing together these two studies, we see that a multi-pronged approach is needed that addresses several layers of the social ecological model. From both of these studies, we found factors that are specific to the mother and infant dyad, but also the interpersonal level, for example, with social influences of the family, and also the practices of medical staff. Prenatal education that expands beyond the benefits is important, and a personalized approach may be most effective in motivating mothers to exclusively breastfeed so that concerns are addressed in advance. You know, really tailoring the counseling so that it meets the mother's needs and is addressing the context in which she has to make decisions. And we must take a closer look at the quantity and quality of the lactation management support provided. So from both studies, we see that there must be adequate staffing there to provide support and to make sure that interventions are happening early during the hospital stay. So this more advanced care should be happening earlier and not waiting until, you know, the concerns become more complex. Next slide, please. So I would like to acknowledge several collaborators and advisors for this project that were very instrumental in completing this work. I would first like to thank the mother, staff, and physicians, there at Grady who volunteered their time and expertise. I would also like to thank the core team as well as the graduate research assistants that provided help with analyzing the data, and my dissertation committee who have been very instrumental in guiding this work, as well as the NACCHO team for their guidance with the webinar. And then in addition to NACCHO, in terms of funding sources, this work was also supported by Emory Maternal and Child Health Center of Excellence. And so thank you to all of the webinar participants for your time and attention, and I am happy to answer any questions that you may have.
So we have received a lot of questions, and I'm trying to group them a little bit. I'm going to be sharing the old slides, another deck, so you'll be able to see the link to the post test. But first here, someone is asking about the term extender. We saw extender showing up there. Can you talk about that?
Sure. So extender for the Grady study included those who extend the care provided by physicians. So nurses as well as lactation consultants, and also included in that were centering program coordinators. So those beyond just the physician.
Okay, thank you. There's also a lot of questions about WIC. I think, well, first it's about breast pumps. So someone is asking that in their state, in the southern part, there is a high demand on Medicaid and WIC for breast pumps. So did you encounter that issue, and what are the factors causing this, and what are the countermeasures, if any?
Yeah, so we did encounter this a bit with the work that we did at Grady. And so what we found is that there was some miscommunications about pumps found in terms of clinicians somewhat being the middleman in communication between WIC and mothers. And we ultimately decided in these working groups that it would be best for WIC staff to answer all questions related to this. As many of you probably know who've worked with WIC before, that WIC has very specific policies for issuing breast pumps and would be the best stakeholder to provide that information. And this would avoid confusion with mothers if they contacted WIC directly to have those questions answered. Okay,
yeah, and along the topic of WIC, there's a lot of WIC questions here. I think you mentioned some moms requested formula in hospital, and then so the questions here are, for WIC, we're letting moms know in advance they can add formula at a later date if they need help. If they need it, does it help? Provided this information up front. And I think it depends on WIC. Some other questions about WIC is, I feel the implication for the WIC component may be subject to that site. How local WIC staff were trained, and it's not reflective nationwide, as well as we have WIC clinics with very high exclusivity and duration rates. And someone is asking, why would taking formula in hospital affect whether a mother gets formula from WIC later?
Yeah,
so can you clarify that? Yeah.
Sure, I think that's a great question. And so the first piece of that included thinking about generalizability of the results from this study. And that is one of the limitations of qualitative work, is that for the Grady work, it is specific to that context. You know, not all hospitals have an in-house WIC clinic, though it's a great facilitator in terms of supporting women and having the services there at the mom's reach where she doesn't have to travel to get additional care. But in this specific context, this is where things became a bit confusing, and mothers weren't necessarily able to distinguish between WIC. They would ask moms, or excuse me, they would ask nurses for formula, thinking that they needed to establish like that feeding plan in the hospital in order to be able to then go on and get WIC formula vouchers later. So some of that came from the extenders, but then also from the mothers too. When we went in to talk with them more during the interviews, we would find that they were not yet using the formula, but kind of just asking for it just in case. So making sure that they understood, you know, that this formula is separate from your WIC formula is very important in distinguishing those two different sources there.
Okay, thank you. We have time for one more question, and the link for the to claim your SERP, LSERP, is in the chat box. You can see it here. But the last question is about doulas and timely support. Well, IBCLCs and doulas and timely support. You did say the consults were driven for the IBCLC support. And is there a study of time that stamps for when the IBCLC offer lactation support is more effective? And also, did you encounter any doulas as the extenders for support?
Yeah, that's, again, great questions. I did not interview doulas, and I'm not sure how present they are in this setting. So they were not included in this study per se, but I think it's definitely something for future research to look into including. And then also, I do not know of any studies that look specifically at the timing of providing lactation consultant help. I do think that, again, those are studies that would be very interesting to look into, to see, you know, when exactly should that support be provided after the mom delivers.
Okay, thank you. There's a few other questions that we can do like a Q&A and send out with this recording. But can you just clarify this one, Laurel? Why would associated demographics, like the lower education levels, fall under medical contraindication?
Yeah, so this is where we were looking to see if there were any connections between the demographic characteristics of the neighborhood surrounding the hospital and the reasons for medical indications, or just the reasons for formula supplementation altogether. That's something that I'm hoping we will explain further in the coming publications. So please stay tuned for that. But we're also looking to shift that analysis to think more about how do the reasons for formula supplementation then correlate with the percent formula supplemented. So that's a part of that, is thinking about these results being preliminary. And then we are hoping to, in future studies, look deeper at the connection so that we can connect to the demographic disparities and potentially think more about focused interventions for those.
Okay, thank you. We look forward to seeing the published study. Thank you, everyone who stayed 3 minutes over. So there's the post-test. For anything, any questions, comments, you can email breastfeeding at NACCHO at any time. And even if you don't need SERPs, which is the continuing education for lactation support providers and IBCLCs, even if you don't need that, please complete the evaluation. It's going to take 30 seconds of your time. Your feedback is really important to us. And thank you so much. Enjoy the rest of your breastfeeding month and have a great afternoon. Thank you, everyone.